Hello and welcome to Bangalore International Centre's very own podcast, BIC Talks. Bangalore International Centre is a platform for informed conversations, exchange of ideas, and a space for arts and culture. BIC Talks brings the essence of all that the physical space stands for and more to your doorstep.
Hi, I'm Pavan Srinath and welcome to BIC Talks. Before we start today's episode, do listen to Ranjan Kamath reading his poem Planet Under Repair. And do stay tuned till the end of the episode when Ranjan returns to read Home Thoughts from Unknown Indians.
Planet Under Repair. Planet Under Repair. From the beginning of time, planet Earth has been benign to humankind. Not perceiving to the planet man was a plague endemic, cursed with craving, every creed controlled by prodigious greed, calling for more than cataclysm or catastrophe, much more than traditional turn or trick, like quake or tsunami. When common sense is not heed, the only solution is total revolution, not revisionism. The extinction of an intelligent species sans conviction to restore nature's balance. An exercise executed with effortless nonchalance by planet Earth. From the times of the pharaohs and papyrus, from when God lent a hand to Moses, then ring-a-ring-a roses, the solution is always the virus unseen, Earth's vaccine against man, and his every dodgy plan to be smarter than his planetary alma mater. While man remains in despair, almost in terror, the skies are bluer, the water cleaner, all looks much greener. Nature undergoes repair. Let's hope we have a second chance to end this dance with death. Let's hope we'll hold life dearer. May it bring us all together, nearer, regardless of community, caste, and creed. Taught a lesson by COVID, that nothing means more than each other. Much loved.
Today we will be talking about the emperor of maladies, cancer. This is a phrase given by Siddhartha Mukherjee. And to talk about cancer today, we have Dr. Hari Menon, who is joining us as a medical oncologist focused in the field of hemato-oncology and works at Cytecare Cancer Hospital in Bangalore. Dr. Menon, welcome to BIC Talks.
Thank you, Pavan. It's a pleasure to be here.
I wanted to start by asking, how are people with chronic illnesses, including cancer, tuberculosis, many other health disorders which need continuous treatment and critical care, how are they managing right now during COVID-19? What are you seeing from your end as a practicing doctor?
So I would say that one of the things that is coming glaringly through is a lot of confusion. There is also a perception that people with chronic diseases, including cancers, may be at an increased risk for getting COVID infection. But I would differ a little bit over there. It is just that unless you are exposed to the COVID infection, you are unlikely to get it. But having said that, many of these chronic diseases are chronic because whether it is diabetes or cancer or tuberculosis, there is always a certain degree of immunoincompetence, as we call it, in these patients. And that is why the fear of getting a COVID infection more easily always is perceived by the common man, or that has been actually propounded by many of even the medical fraternity. And also the fact that when we are treating cancer patients, they do get immunocompromised to a certain extent, which also gives the fear that they might get COVID infection. Our center, at least, we have not had so far any COVID positive patients or had difficulty in giving treatment just because COVID is there in the community.
Dr. Hari, a couple of specific follow-ups on this. So one, when the lockdown happened and when the pandemic started showing up with COVID positive cases in Bangalore, Karnataka and India, did you see a challenge with people who were currently on chemotherapy, who had to come in weekly or monthly? Did you see some of your patients face challenges just to keep an ongoing treatment regime?
Not really from the perspective of delivering the treatment, not really from the perspective of tolerating the treatment, but certainly from the perspective of being able to come to the hospital to get their treatment done. So most of the time, it was a challenge for getting to the hospital actually to get their treatment.
Thank you. And the other follow-up was, so in this lockdown period, lots of things have come to a halt or been reduced significantly. And in cancer, we often talk about early detection perhaps being the only way to manage a lot of cancers. So in that sense, do you have a fear that there might have been people who might have missed diagnostic appointments in the last few months because of the difficulties in just getting to a hospital and getting the care that they need?
In a way, yes. And also, I would say not such a big problem either. Because as we know, most cancers, the problem has been always that people tend to neglect symptomatology that comes up and they do not come forward to get investigated. And that has not really changed. So many a time, patients have symptoms on an average of 3 to 4 months before they actually seek attention, unless, of course, you have a patient who develops something like a leukemia or a very, very aggressive tumor that is growing so fast that they become very sick too quickly. So I don't think that has been a real problem in terms of accessibility to getting investigated. It is again got to do with the mindset of people in wanting to delay coming forward to get investigated. So yes, we also should understand that screening tools, and while it has been popularized that early detection of cancer is definitely going to improve outcomes, I will not say otherwise, but those are true for a handful of cancers actually. But having said that, screening is sometimes gives a lead time bias, as we would call it, in terms of identifying, and 3 months or so would not have made that much of a problem in these patients.
Thanks, Dr. Hari. So I want to take a few steps back before we dive into various aspects of cancer and its treatment. Cancer still has a lot of stigma associated with it. While you've been practicing, what kind of stigma or concerns do patients come with most often? What do you need to counsel them on most?
So this is a very pertinent question, and believe me, it is a major issue for patients to come forward to get themselves treated, especially among women, because cancer is always more than not equated with death, which is not actually true. It's far from the truth, actually, because I always tell my students and even the relatives and the patients who come in automotive that you have a disease that is more amenable to cure than many other illnesses that you see in medicine. And there is a misconception that cancer is hereditary, when the truth is that less than 5% of all cancers are actually having a hereditary pattern to it. So yes, less than 5%. Yeah, even when you talk about breast cancers, which we are always very active in searching out, looking at their family tree. Even in breast cancers, we do understand that only 5% or so of breast cancers are actually hereditary. So most of the cancers are acquired, and it is just like any other disease that needs to be dealt with in a systematic manner. Many a time I get the common question, can I sit with my family and have food with them? Can I share a room with them? Can I share a bed with my wife, or vice versa? All these things come up when there is not an iota of truth in there. It is my favorite statement is that your cancer is all yours. You can't share it with anybody else.
So in fact, you're sharing stories of stigma that were associated with AIDS, which is an actually infectious disease, but infectious in very, very specific modes. But it's disheartening to know that you have this kind of stigma for a non-communicable disease in India.
Absolutely. And also, I tell them that it can happen to anybody. Just because you had cancer doesn't mean that your child or your relative is going to have cancer. And also, it is something that is continuously forming in your body. Cancer cells are evolving. in your body, and we have such a robust immune system that is existing in your body, which actually keeps eradicating those unwanted cells in a dynamic fashion. So another statement I'm always fond of telling is that even as I'm talking, there are millions of cancer cells being formed in my body and being eradicated by my immune system. But at the same time, we do say that if you don't take care of your health, and if you don't have a reasonably healthy lifestyle adopted, your chances of getting cancer are going to be high. And that is true mainly for solid tumors. We try to classify cancers into those associated with the blood and blood forming organs, and those that are the solid tumors like breast cancer, lung cancer, or anything coming from any of the organs. So we do understand that most of the solid tumors, as we call it, about 30% of them are actually lifestyle associated. And that is what the data has to say.
By lifestyle, do you mean is the biggest burden coming from tobacco?
You name it, there is not a single cancer that cannot be associated with consumption of tobacco in any form. And the other things that are associated with is obesity. For example, some of the common cancers that are associated with obesity is breast cancer, colorectal cancers, sometimes some of the pancreatic cancers, and so many other cancers. But things that come to mind, the commonest cancers, breast cancer and colorectal cancers, are quite associated with obesity. And then the type of food that you eat, less of roughage, etc., tends to increase your chances of colorectal cancers, which is clearly been demonstrated in terms of the epidemiological emergence of increased number of colorectal cancers in India, wherein colorectal cancers was relatively lower in the Indian population. Now it has come out to be almost the second or the third commonest malignancy among the men and women today.
But a related question, Dr. Hari. Often especially you read news articles of various types. Everything on earth seems to be a carcinogen. One day coffee is a carcinogen, the second day coffee will help you against cancer. Chocolate will do something, wine will do something else. So there's been this growth in this industry of classifying various things as carcinogens. Do you think this is largely productive to the discussion and our understanding of cancer, or is it a distraction and almost a myth?
Yeah, I'm a little bit for moderate as far as this is concerned. I would say that things such as tobacco, a lot of fried stuff, smoked stuff, all that may contribute and on a regular basis, taking it on a regular basis contributes to development of malignancies related to that. So let us put it this way. Suppose you do have a genetic predisposition, which we're talking about in the 5% or so of the population, and you add an environmental stimulus to that, be it taking a tobacco or taking some oily food, and also then have a trigger towards this, such as an infection which might happen. Everything put together will actually, it's like a jigsaw puzzle, and things will fall into place and you get manifest cancer in those patients. So there is always this double hit and triple hit theory in oncology that we talk about, that it may not be just one hit. You may be predisposed to a cancer, but unless you have a hit for that, you may not have a manifestation of the cancer.
What about when somebody comes with cancer and is diagnosed with cancer? You mentioned that the looming prospect of death is no longer as true as perhaps it once was. So could you tell us typically, maybe with a few examples, what patients sort of go through and what their treatment is like once they come in and once they've been diagnosed? Given that your specialization is in hemato-oncology, perhaps you could talk about that as well.
So first, coming to my specialization, which is in hemato-oncology, which I've been dealing with the past 20 years or so. In hemato-oncology is something like almost like an all or none law. Either you treat and cure or you don't. But we do have distinct subset of patients whom we can control and have almost a normal life despite having the disease in the background, like how we would treat diabetes or hypertension, or for that matter, even cardiovascular diseases, in terms of controlling the disease.
Dr. Hari, so you largely deal with various forms of leukemia, right?
Yes.
Are there any non-leukemia type cancers also that fall under this bucket?
So when we talk about cancers related to the blood and blood forming organs, we broadly say about blood cancers, which are called leukemias, and we call about cancers related to the lymph nodes, which are known as lymphomas. So broadly, leukemias and lymphomas are the things that we deal with. There are so many different forms of leukemias which behave differently. Some of them are completely cured, and it is just like an infection. You treat them well, and then they're cured. But giving that kind of a treatment may be quite intensive. Patient has to go through a lot, but at the end of the day, you're going to get cured. One of the best examples of targeted therapy has been in a specific leukemia known as chronic myeloid leukemia, wherein the biology of the disease is such that the trigger and the driver of the leukemia, the generation of an abnormal protein that forms in the body, which actually triggers the leukemic process or the cancerous process. So research led to the fact that if we can block the activity of this protein, then we can reverse the leukemia completely. And that was what happened in treating chronic myeloid leukemia. We had a molecule which could block the activity of the protein, and that completely changed the picture as far as chronic leukemia is concerned. And today, when we have a patient with chronic myeloid leukemia, we are confident in telling them that you have every chance of living a normal life. Only thing is that you have to take the medicine like a patient with diabetes or hypertension who has to take the medicine to keep the disease under control. We have so many things that are treatable in cancers, but we should also recognize the cancers that may not be treatable. And the outcomes of such cancers may completely depend upon what the stage of the disease might be. So that is what we do when a new patient comes in with a suspected malignancy. We try to first identify what that malignancy might be. Once we have identified what the malignancy is, we go to the next step of understanding what is the extent of the malignancy. This I'm talking specifically for solid tumors. And once we have identified the extent of the malignancy, we then start strategizing as to which is the best approach. Can this tumor be surgically resected? Because the rule of the thumb is that for any solid tumors, when you are treating them, if they can be surgically removed in toto without any residual disease left, then you have given them the best chance of survival over there. So that is true whether it is breast cancer, that is true whether it is lung cancer, that is true whether if it is a prostatic cancer, and most of all the cancers that we deal with in what we call as solid tumors. So many a time we encounter that the disease has spread beyond the confines of a surgical intervention. And in that situation, we see whether we can bring it back or pull it back to a certain extent with some treatment. And thereafter, can we explore a surgical procedure for that? So in those situations, we also have to determine whether that tumor is going to be sensitive to a particular form of treatment. And we know from our data which is the tumor that is going to respond, which is not going to respond. So if you have a tumor that is going to respond very well, then we are more than happy to institute a specific treatment, be it chemotherapy or on more rare occasions, any targeted therapy to get the disease under control. And once the disease comes under control, then subject them to a surgical procedure. And suppose we are able to bring it under control and still not able to offer a surgical method, then we think about also the option of radiation in these patients. Radiation is a key treatment in many solid tumors and is always exercised judiciously. So we do none of the treatment paradigms, which is whether it is surgical, whether it is giving chemotherapy, or whether it is giving radiotherapy, is mutually exclusive. They are all part of the composite approach to treat malignancy for optimized outcomes. It doesn't matter. You might use surgery in the first setup, or you might use radiotherapy in the first setup, or you might use chemotherapy in the first line. But somewhere down the line, in most solid tumors, we do exercise the option of one of these modalities or all the three modalities at some point of time. So the classical example is treatment of breast cancer. Primarily, if it is amenable to a surgical procedure, that would be something that we would offer these patients. And thereafter, depending upon the characteristics of the tumor and what we call as the biology of the tumor, and also what we see in the pathological specimen under the microscope, we determine, is there any need for additional therapy for these patients? And the additional therapy are clearly defined by certain criteria. And if those criteria are met, then we do give chemotherapy to these patients. And the chemotherapy is primarily with the objective of taking care of any microscopic spread that might have occurred in the body. Because today, more than not, believe that any solid tumor is not a localized disease. It is more of a systemic disease. Only thing is that it is manifest in one particular location. So that is true for breast cancer, which we consider as a systemic disease. And we give chemotherapy when required in these patients. And again, we do understand that many of the women nowadays would not like to go for a radical surgery. So cosmesis has become an important part of treating these patients. It is something that we take cognizance of and are very concerned about, because they are going to get back into mainstream after the treatment, and they would not like to have any sort of radical surgeries seen on their body. So if that is the case, then we have to exercise radiation also. And of course, all these modalities will come into the picture even in advanced stage disease, wherein our objective of treatment would move away from a curative part to an intent to control the disease, improve the symptoms of the patient, and improve the quality of life of the patient. So it's a very, very careful decisions that have to be taken when a patient comes in with a diagnosis of cancer. Not only planning on what needs to be done at that point of time, there is a need to also plan for the future, a need to anticipate problems or complications that might develop in the future and take measures or be prepared for. So no two patients are the same. Many a time patients tend to compare that, oh, I was treated this way and you were treated in a different way. But we must understand that even though protocols are there to be followed for a defined criteria, maybe no two patients might receive exactly the same treatment, because the biology of the disease can be quite different.
In this, I want to ask sort of one final question, which is that given that cancer causes so much anxiety, so much concern, even while going through chemo and radio and surgery and so on, it can feel like a death sentence that is there in the distance. The need for counseling, for support that is non-medical becomes very important, right? So could you tell us a little about how that is activated in practice at hospitals like yours?
So we do have psycho-oncology unit which functions independently. And as a matter of routine, whenever a new patient, or for that matter, when a patient, if he requires, when he or she comes on a follow-up, they are seen first by the psycho-oncologist, assess their anxiety levels. And actually, the psycho-oncologist, after making that 10 to 15-minute assessment, they go through a questionnaire and make an assessment as to what is the anxiety level of the patient, and also communicates that there are certain red flags that come up. And if that is the case, they would come over and tell us that there are these. So we try to then modulate our approach to the patient accordingly. Now, what you said is correct. The anxiety stems from the fact that from time immemorial, cancer has been associated with mortality. There's no way. It is almost like a 1:1 association with it, which is not true. One of the biggest challenges that I sometimes face is the fact that the relatives or the caregivers of the patient keep frantic. They will come first to your room and say, don't say anything to the patient, because they will not be able to tolerate they will not be able to accept the diagnosis. And I have to counsel them first before I can actually call the patient and tell them that this is the most crucial part of start of treatment for the patient. And if we need to get the treatment started, the patient should be accepting of the treatment. Otherwise, if they do not know why they are going through all this hell of toxicities and side effects of the treatment, which is a reality. I will not say it is not a reality, but then it is important. It becomes easier for them to go through with the treatment if they know what they are going through, rather than being in the dark.
Dr. Hari, thank you so much. I think all patients, we are looking for more communication and more assurance from them. And I think from oncologists, it becomes even more paramount. So thank you for taking the time and talking to us on BIC Talks about cancer, the practice of medicine, and about the various challenges that are there on the doctor's end as well while treating patients with this disease. Thank you so much.
Thank you, Pavan. Thank you so much.
Dear listener, thank you for listening to our episode. And now, here's Ranjan Kamath reading Home Thoughts from Unknown Indians.
Home thoughts from unknown Indians. Confined as we are homebound in our human zoos with lots and lots or nothing to do, I thought there'd be nothing to lose discovering their different points of view about the present and future too, their choices, what they would do. I was appalled by the quarantine order, since I'm a chronic handbag hoarder. Just the day before, Louis Vuitton called, informing me, please collect from UB Mall. Now I've reacted with a depressive disorder. 40 days my new Porsche 911 is rotting in the basement, wrapped in polytetrafluoroethylene encasement. I ask you, what harm if my success wears a crown driving through town, hood down? Our egos too need an anointment. This deadly diet of quiet brought me to the brink. My brain got fried just listening to me think. There was total silence. I heard nothing. Then I did hear. It was my stomach growl. Talking about diet, there isn't a moment's quiet with internet reverberation about workouts, meditation being the final solution, fitness fanatics pleading you, sign up to begin your inner transformation. Not true. No, thank you. When I'm not watching Netflix, most therapeutic is a snooze or a snack out. Jesus H. Christ, 40 plus days, no bloody smokes, no alcohol, but mouthwash. Imagine my misery. Also, no drink, surviving on fruit squash. I felt my life draining down the sink. An efficacious cure for boredom is a daily dose of voyeurism. So 24/7, I'm logged in Facebook to discover what friends cook, their pouting pets, gardens with roses, their book collections, other predilections, a peeping Tom into their personalities, and of course, updates on corona fatalities. For 40 years, I fantasized of foursome. These 40 days I went on Tinder. Just look at my luck. I found Brinda, Lucinda and Rajinder also dying of boredom, cursing the lockdown, excited. The waiting has been lonesome. What a nightmare! Working from home, fighting for bandwidth, screaming, oh shit, my net has dropped. In different rooms on different calls. Fortunately, we only meet in the kitchen at the microwave when we need to eat. Have you any idea what it's like to manage house? No, you can't count on the spouse without a maid. What splendid irony. I'm working twice as hard in absentia. She is getting paid. I look at piles of dishes. I whoosh, they disappear. Sweeping and swabbing is great for my glutes, but leaves me pining for a beer. I miss zigzagging, creating disruption on the wrong sides of the road. For road rules, I give a toss. No one listens if there's no honking boss. You must be right even when you're wrong. That tells them they're weak. Show you as strong. Me too. I stare at empty roads, KTM dying for a spin, terrorizing the neighborhood, doing wheelies, breaking the sound barrier. I want to yell, I am a corona carrier. With zero traffic anywhere in town, they're thrilled that CO2 is down. What joy! Particulate matter is less. Idiots. They don't realize it's pollution. That's what would have killed the virus. Now, what's the point of clean air if I'm breathing through a mask? Do they think about the economy going up in smoke? That I might get a pink slip? Worst of all, I'm nearly broke. What's all this talk about common good if I don't have a livelihood? To those thrilled they see the Himalayas from home on a clear day, I say, get back to work, do us a favor. You can see it anytime on your screensaver. Flamingos, dolphins, how terrific. They're already on National Geographic. So what if Ganga is cleaner, water fit to drink? I've been brought up on Bisleri before I began to think. These migrant workers call themselves patriotic, deserting the economy. Walking home is idiotic. Halting work on building sites just isn't right. These miscreants, blunting India's economic might. What about my investments in a dozen flats? Just imagine my plight. Please think of that. Screw these workers. Let them go home. They'll be the ones to starve. What is it they contribute? What is it they have? We'll make in India a new future, carved out with tech and AI. Nature and diseases dare not us defy. We'll place robots on assembly line. Blame consumerism, blame globalization. The system's fine. Why do we need to change? Self-reliance requires the arrogance of science. The threat most immense is these deranged minds with their tsunami of common sense. The human is not what he used to be. He's in dire need of improvements. Hence, it's time to replace natural stupidity with artificial intelligence. Yeah, if this battle with SARS too long continues and proves a pain in the ass, that's cool. We'll cut our losses, pack our bags, dump planet Earth, and move with Musk to muck up Mars.
Thank you for listening in till the end. Please share this episode with a friend on social media, WhatsApp, or anywhere else. It would mean the world to us. And in case you're listening via iTunes or Apple Podcasts, please leave us a rating and a review. Subscribe to BIC Talks on email or your favorite podcast app and don't miss out on future episodes. This episode of BIC Talks has Gaurav Krishna as our sound engineer with support from S. Sarvanaraj and Lekha Naidu. And the accompanying episode artwork was made by Chandni Venkataraman.
Thank you for listening to this episode of BIC Talks. This podcast can be accessed on our website, bangaloreinternationalcenter.org, as well as on any of your favorite podcast platforms. Tune in for new episodes every week, and do subscribe to our YouTube channel and follow our Facebook, Twitter, and Instagram pages to stay informed on our latest updates.